Well, it's my great pleasure to introduce Dr. Manjula Tamura today, who I personally had the distinct fortune of learning from as a nephrology trainee during my fellowship. Dr. Tamura is a distinguished professor in nephrology and a clinical researcher at Stanford University, as well as the Palo Alto VA healthcare system. She has a very extensive research profile. It focuses on health services and outcomes in aging populations with chronic kidney disease, evaluating the benefits and harms of various treatments, particularly dialysis and hypertension management. Just had many prestigious leadership roles. I'm gonna look at here for a few, including Director of Clinical Research for the Stanford Division of Nephrology. She's also Director and Service Chief for the Palo Alto VA Geriatrics Research and Education Clinical Center. She's an Associate Editor for CJASN, Executive Committee member for the Palo Alto VA Center for Innovation to Implementation, and also has been co-PI of the US RDS Special Study on Palliative and End-of-Life Care, just to name a few. Dr. Tamura's work has been instrumental in shaping clinical practice and advancing healthcare policies and improving patient-centered care in nephrology. So without further ado, please join me in welcoming Dr. Tamura.
Lost the microphone. There we go. So thank you, Daniel, for that really kind introduction. I think it will surprise no one if I mention that Daniel was one of our most outstanding fellows when he was at Stanford. So you got a good one. It's such a pleasure to be here. Yesterday I had the great fortune to visit with old friends and meet some new ones. And it was such a fun time. I had the opportunity to present some of the work that we're doing on hypertension and chronic kidney disease at the KRI yesterday. And today I'm going to talk about sort of a related idea that I have been thinking about for the last few years about hypertension and heart failure and kidney disease and the management of that. So this is sort of a new area for me. So bear with me. I'm still sort of forming some of my ideas here. I don't have any relevant disclosures. So I'll start here and say this is really an exciting time for us in nephrology because after more than a decade of having really only RAS blockade to prevent chronic kidney disease, we now have lots of exciting therapeutic options. We have SGLT2 inhibitors, we have mineralocorticoid receptor antagonists, and now we have GLP-1 receptor agonists. And now we have all of these options. And this raises a lot of interesting questions, both mechanistic. How are these agents acting to prevent and delay progression of chronic kidney disease? But also some interesting clinical questions like which patients, which agents for which patients, when should we start? What are the optimal combinations of these therapies? The KDIGO guidelines that Ian worked on suggest a risk-based approach. The first line for most patients will include an SGLT2 inhibitor, a RAS blocker, and a statin. And then depending on the patient's characteristics and additional risk, we might consider a nonsteroidal MRA for patients who have additional proteinuria and are at risk for progression. For patients who have resistant hypertension, we might consider a steroidal MRA. And so this is part of the set of ideas that I want to dig into a little deeper today. So the rationale for providing additional therapy on this baseline of SGLT2 plus RAS inhibitor comes from data like this, demonstrating that despite an ARB and SGLT2 therapy, there remains fairly high residual risk for progression. This is data from the Credence study that shows the residual risk among the patients who were enrolled in this study. The risk for CKD progression in Credence at 3.5 years was about 11%. You can see it was similar in the other SGLT2 trials, and the residual risk for cardiovascular events also remains substantial. And this is data that just came out last week in the New England Journal, the long-term follow-up from the EMPA-REG study group, showing that at 4 years, 4.5 years, the excess risk for kidney and cardiovascular events was a sobering 35%. So, there's still quite a bit of work to do. We can delay progression, but clearly we're not preventing cardiovascular kidney events optimally. And this really forms the foundation for proposals that we don't have step therapy, but really 4 pillars of simultaneous therapy with RAS blockade, SGLT2 inhibitors, MRAs, and GLP-1s. So while it's really exciting to have all of these new therapies at our disposal, that presents us with also a new set of challenges, both in facilitating recognition of who should get these therapies, but then also how do we facilitate access to these therapies and implementation of them? And this is one of the main barriers, cost. This was a study from JAMA Network Open looking at the out-of-pocket costs for CKM therapies. Here they were thinking about it from a heart failure perspective, but the same sort of ideas apply. If you were to look at the out-of-pocket costs and Medicare Part D plans for GLP-1 plus SGLT2 plus non-steroidal MRA, you can see that's more than $5,000. And that's pretty much out of reach for a large proportion of patients who are affected by these conditions. Alternatively, if you look at the estimated out-of-pocket costs for a regimen that's based on generics, again, here using heart failure as an example, so a generic beta blocker, a generic ACE, and spironolactone, the out-of-pocket cost is about $500. If we add an SGLT2 to it, it's about $2,000. So half of the cost of having, the 4-pillar therapy. And so thinking about this question, I've been mulling this over for the last few years. And I thought of this essay from Malcolm Gladwell. I don't know how many of you read Malcolm Gladwell or the New Yorker. He had this essay several years ago called The Catch-Up Conundrum. And what he describes is that food scientists, when they do taste tests of lots of different products, and he used pasta sauce as an example, they can identify different taste preferences. So among us in this auditorium, there are those of us who prefer garden vegetable. There are those of us who prefer meat sauce. There are those of us who prefer cheese sauce. And there are those of us who prefer marinara, for example. And that's why, and this pretty much holds for lots of different products. That's why you see at the grocery store aisles and aisles of pasta sauce and cereal and soda, right? We have different preferences. We have different characteristics that lead us to these different tastes or preferences. But ketchup is different. Heinz ketchup is the undisputed king of condiments. It is. When you do taste tests, Heinz ketchup versus anything else, 90% plus people prefer Heinz ketchup. It has this amazing combination of sweet, sour, salty, and umami that just beats everything else every single time. And so the question that came to my mind is finerenone the Heinz ketchup of mineralocorticoid receptor antagonists? Is it the MRA that redefines MRAs? Or is it just another pasta sauce in the pasta sauce aisle? So that's sort of the question I kind of want to explore today. So to restate that from a clinical standpoint, are there clinically important differences in the efficacy and side effect profile between steroidal and non-steroidal MRAs for patients with kidney disease? So here's a roadmap that I'm going to walk us through. We're going to talk a little bit about mineralocorticoid receptor activation and the pharmacology of MR antagonists. This is coming from an epidemiologist, so bear with me in my description of pharmacology. And then we're going to dig into some of the clinical data on MRAs. I'm going to focus on MRAs for heart failure because that's where a lot of the data is. And then we'll talk a little bit about MRAs and proteinuric and non-proteinuric CKD. I'm not going to spend time today just for time talking about resistant hypertension. I think that's probably a separate talk in itself. And then I'll give you some closing thoughts. Okay, so let's first talk about aldosterone regulation and action. So I think you guys could probably describe this axis better than I could, but when blood pressure drops, the kidneys release renin into the bloodstream. Renin is converted into angiotensinogen and then into angiotensin 1. Angiotensin 1 is converted into angiotensin 2 in the lungs and the kidney. And angiotensin 2 stimulates the adrenal gland to release aldosterone. There is a phenomenon known as aldosterone breakthrough, which has been described in anywhere between 10 to 50% of patients with proteinuric CKD. And it's the idea that despite RAS blockade, there are elevated levels of aldosterone in these patients. And it's this aldosterone breakthrough that is thought to mediate some of the residual risk for progression of chronic kidney disease in the patients that we treat. So aldosterone, as you digging back to our physiology classes, aldosterone is synthesized from cholesterol in the zona glomerulosa of the adrenal gland, and it acts as a ligand for the mineralocorticoid receptor. It mediates its effects through both genomic and non-genomic pathways, and that's sort of illustrated here. The genomic effects occur as it binds to the mineralocorticoid receptor in the cytoplasm and then gets translocated to the nucleus of the cell and then acts as a transcription factor. And that response occurs on the timescale of like 30 to 60 minutes. And then there is also a more rapid non-genomic pathway where aldosterone binds to mineralocorticoid receptor in the cell membrane, and that mediates a more immediate effect. The effects are both in epithelial cells, like the principal cell of the kidney that we're familiar with, but also in non-epithelial cells. And it's these effects in non-epithelial cells like cardiomyocytes, vascular smooth muscle, aldosterone, that have been recognized in more recent years and are thought to mediate some of the effects of what we now call CKM syndrome, things like inflammation, the cardiac fibrosis and remodeling that we see. So I'm not going to pretend to be a pharmacologist and explain the pharmacology. Just wanted to sort of show all of the different mineralocorticoid receptor antagonists that are available and in development. In the middle is the steroidal MRAs. Spironolactone was the first that was developed and is the one that we're most familiar with. Eplerenone in the middle is a non-selective steroidal MRA. Canrenone is actually a metabolite of spironolactone, and it's the metabolite that is the active metabolite of spironolactone. It has a very long half-life, It's actually its own drug available in other countries, but not available in the US. And then the non-steroidal MRAs are shown in the last row. I'm going to really focus the rest of the talk on finerenone as the non-steroidal MRA, but just for understanding, there are multiple other non-steroidal MRAs that are in development or in phase 2 testing now. So spironolactone and eplerenone are considered flat or planar MRAs based on how they bind with the mineralocorticoid receptor, whereas finerenone is a bulky MRA. In terms of the other properties that are relevant and thought to be responsible for some of their pharmacologic differences, spironolactone has very high potency with the MR, whereas eplerenone has low potency. Conversely, eplerenone and finerenone are much more selective for the MR, whereas spironolactone is not selective, which means that it can bind to other ligands other than the mineralocorticoid receptor. And that is why it has some what we would consider off-target effects or sexual side effects like gynecomastia or its potency for treating conditions like hirsutism. In terms of half-life, we talked about the metabolite of spironolactone, canrenone, stays around for a long time, so it has a very long half-life. On the other hand, eplerenone and finerenone have very short half-life. And then finally, their tissue distribution also differs. Spironolactone is distributed much more in kidney than in heart, reportedly 6-fold difference. For eplerenone, that's about a 3-fold difference, kidney versus heart tissue distribution. And finerenone is reported to be equivalent to tissue distribution, kidney and heart. So on the left-hand side is what happens at the aldosterone's action in the principal cell. So aldosterone diffuses across the cell membrane, binds to the MR in the cytoplasm, along with this coactivator, gets translocated into the nucleus and acts as a transcription factor for pro-inflammatory product genes. It also prevents the ubiquitination of ENaC, and that leads to driving sodium reabsorption into the principal cell and the efflux of potassium out of the cell. For steroidal MRAs, they also diffuse across the membrane, bind to the MR along with the coactivator. So there is a transcription of these pro-inflammatory and pro-fibrotic genes. However, it prevents the ubiquitination of ENaC, so it prevents the reabsorption of sodium and then the efflux of potassium out of the cell. So the reported difference for non-steroidal MRAs is that when they bind to the MR in the cytoplasm, the coactivator does not bind. And it's this difference that is thought to relate to differences in gene transcription. So you don't see an increase in transcription of pro-inflammatory and pro-fibrotic genes. And that's proposed to be one of the mechanistic differences between these different agents. Okay, so I'm going to shift gears now and really dive into the evidence. So we'll start by talking about MRAs to treat heart failure in people with kidney disease. And we'll go through both the trials overall, then their effectiveness in people with CKD, their effects on kidney relevant endpoints, and then finally some of the head-to-head studies. And so we'll start with rails. as some of you know, RAILS was really the landmark trial of steroidal MRAs in heart failure. It was 20 years ago now, I think, that RAILS came out. And it was a trial that added spironolactone onto the standard of care for heart failure at the time, which was RAS inhibition. So 95% of the people in RAILS were on an ACE inhibitor. The trial included about 1,600 people with what we would now call heart failure with reduced ejection fraction. Importantly, it excluded people with a serum creatinine over 2.5, and it also excluded people with a potassium of over 5. And what they found was really practice changing. This very dramatic reduction in mortality, a hazard ratio of about 0.65. This finding was rapidly followed by a series of additional trials of MRAs in heart failure. First, on the bottom left, Ephesus. Ephesus was a trial of starting eplerenone post-MI in people who had reduced ejection fraction post-MI. You'll see it's a very large trial, more than 6,000 patients in multiple countries. Again, more than 85% of the patients were on an ACE or an ARB. Again, excluded people with significant renal dysfunction. So they excluded people with a serum creatinine of more than 2.5 or potassium of 5. And again, demonstrated that there was a pronounced benefit of adding an MRA to the standard of care for heart failure. Emphasis on the top right was a trial, again, using eplerenone, again in heart failure with reduced ejection fraction, but this time not in the setting of post-MI. Again, on the standard of care of ACE or ARB, similar exclusions, except this time based on GFR. And once again, demonstrated a pronounced benefit of MRA on top of ACE inhibitor therapy for heart failure with reduced ejection fraction. And then finally, TOPCAT. TOPCAT is different in that this was the first MRA trial looking at people with heart failure with preserved ejection fraction. Again, on top of the standard of care, ACE or ARB, excluded people with a GFR of less than 25 or a potassium of more than 5. TOPCAT, the overall result was non-significant, so they did not find a significant benefit of the MRA. However, a post-hoc analysis which stratified the results by site demonstrated a benefit of the MRA consistent with the prior trials when they excluded the patients who had been recruited from Russia. And when they dug deeper into this, they found that the patients who had been recruited from Russia had much lower BNPs and much lower mortality rates, which suggested that these weren't really patients with heart failure. So take the TOPCAT, interpret it as you will, as either a potentially positive study or an overall negative study. But my interpretation is that it's consistent with the overall story that MRAs appear to be beneficial in people, certainly with heart failure with reduced ejection fraction, and provide some evidence that it may also be beneficial in heart failure with preserved ejection fraction. So then this is a pooled analysis of these 4 trials, RAILS, Emphasis, Ephesus, and TOPCAT, looking at the efficacy of MRAs versus placebo across a spectrum of kidney function, so stratified by GFR. And there are a couple of points that I'll make here. First, for all of the GFR strata over 30, there is a significant benefit of the MRA versus placebo. Although the effect sizes sort of attenuate as the GFR drops, you'll see that the number needed to treat is still quite convincing in all of the patients, the strata with CKD. So 46 to 60, a number needed to treat of 32. For the people with a GFR of 31 to 45, a number needed to treat of 15. I mean, that's really low for most of the therapies available to us. Now, the strata with a GFR of less than 30, there was not a significant benefit of MRAs. But keep in mind that most people with a GFR of less than 30 were excluded from these trials. So this should be interpreted cautiously. Okay, so from the same pooled analysis of these four trials of steroidal MRAs, this analysis looks at the safety of steroidal MRAs versus placebo, specifically hyperkalemia events and then worsening kidney function. These are not laboratory defined, or at least the way that they reported it. So these are investigator defined events. And you'll see that within each of the GFR strata, there are higher rates of hyperkalemia with the MRA versus the placebo. Similarly, higher rates of worsening kidney function with the MRA versus the placebo. But more importantly, the rates for all of these events, for the hyperkalemia events, increase with lower GFR. So for people with a GFR of less than 30, in the MRA group, 30% of the patients experienced an investigator-reported MRA, hyperkalemia event. Okay, so I'm going to move on and talk about some of the head-to-head trials now with non-steroidal MRA or finerenone versus the steroidal MRA. And the first real head-to-head trial was this trial called ARTS. And it enrolled adults with heart failure and a reduced ejection fraction who were on evidence-based treatment. And they had two strata, one strata that they called CKD-A. They had a GFR 60 to 90. And the second strata with a GFR of 30 to 59. And I'm going to focus on strata B here in the next slide. Like the big trials, they excluded patients with a potassium of more than 4.8. And they randomized the patients to different doses of finerenone, ranging from 2.5 to 10 milligrams, placebo, or open label spironolactone between 25 and 50 milligrams a day. Here are the results. So on the left-hand panel, what you see is a dose-dependent effect of finerenone on potassium. So the blue marker is its effect, I think, at week 4. The red marker is at week 6 or 7. And so between here and here, these are the dose-dependent effects of finerenone on potassium. With higher doses, there's an increase in the potassium. And then this is the effect on spironolactone. So there appears to be a difference in the increase in serum potassium between the finerenone groups and spironolactone. If we look at eGFR and blood pressure, we'll start with blood pressure. We can see that there's not really a dose-dependent effect of finerenone on blood pressure. There seems to be similar blood pressure lowering at different doses, an effect of between 2 to 4 milligrams of millimeters of mercury, pardon me. Conversely, spironolactone has a much larger effect on lowering blood pressure, and presumably it's this hemodynamic effect that explains the effects on GFR. Spironolactone is associated with a larger reduction in GFR compared to. So ARTS was followed by another trial called ARTS-HF. This time it was a comparison of finerenone and eplerenone. So similar population, adults with heart failure and reduced ejection fraction who were requiring hospitalization and IV diuresis. and either had type 2 diabetes or CKD. And here are the different GFR strata. They were already on evidence-based therapy for heart failure, and they excluded people with potassium over 5. And they were randomized to different doses of finerenone, titrated up versus a eplerenone, starting at a dose of 25 milligrams every second day with the goal to titrate it up. The primary outcome in ARTS-HF was the change in NT-proBNP level. And then as an exploratory analysis, they looked at changes in, or the risk for death and cardiovascular events and safety events. And here's what they found at day 90. On the left-hand side is the change in the NT-proBNP level. The eplerenone dose is right here, and then these are the escalated doses of finerenone. You can see that kind of the same proportional reduction in NT-proBNP levels between eplerenone and the different finerenone groups. The right-hand panel shows the differences in cardiovascular events between the different dose groups. And so you see here that the risk for the event, eplerenone was inferior to doses of finerenone at 10 milligrams or higher, suggesting that finerenone was superior to eplerenone. However, I'd make a few caveats about this analysis. First is that this is an exploratory analysis, so the study wasn't powered to identify these differences in mortality and cardiovascular events. The second is that there may have been a baseline imbalance between the eplerenone and finerenone groups. If you look at the appendix of the paper, the baseline BNP levels are different between the finerenone groups and the eplerenone groups. So the eplerenone group had a higher BNP level. And the primary result, the proportion of reduction in BNP, was actually reported in only a small fraction of the trial participants. They don't really explain this. So there were more than 200 or 150 participants enrolled in each group, but between 60 and 70 had their BNP levels measured. So I do wonder if this is a chance event, some luck of or unlucky randomization led to some baseline imbalances. In terms of the safety, we see that the eplerenone group had a slightly higher potassium level compared to the different finerenone groups. There did seem to be a dose-dependent increase in potassium level at the highest levels. However, if we look at clinically significant hyperkalemia events, there was actually very low incidence of potassium over 6 in any of the doses, eplerenone or finerenone. And similarly, if we define this as the potassium greater than 5.6, there were really not any clinically significant differences between eplerenone and the different doses of finerenone. How long do I have till 9:30? Okay. So that brings us to fine arts, which I think many of you have heard about, came out last year. Fine arts enrolled people with symptomatic heart failure and an ejection fraction of more than 40%. So really the heart failure with preserved ejection fraction population, excluded people with GFR less than 25 or potassium of more than 5, and randomized people to a dose of finerenone between 20 and 40 milligrams, depending on their GFR versus placebo. And the primary outcome was hospitalization for heart failure or death from cardiovascular causes. And as I'm sure you've heard, they enrolled more than 6,000 participants. 70% of them were on an ACE or an ARB, so somewhat lower than some of the other MRA trials. Conversely, about 13% of them were on SGLT2 inhibitors and demonstrated a large effect of finerenone for reducing cardiovascular events and death. If we look at the stratified analyses by relevant subgroups, we can see basically similar effects by GFR, more than 60 versus less than 60 for the presence of albuminuria. If we look at the kidney endpoints in fine arts, we can see that the finerenone group experienced an acute drop in GFR, presumably a hemodynamic effect, and then the rate of progression over the longer term, the slopes here appear to be similar. So there's a clear signal here that finerenone reduced the risk of progression of chronic kidney disease, but with the caveat that this is a population at low risk for progression to end-stage kidney disease. The median urine albumin to creatinine ratio was only 18. Finerenone in this population did reduce albuminuria, but as I just said, this is mostly a population without a lot of albuminuria. It did reduce new onset, both micro and macro albuminuria. Okay. So this is a paper that just came out last year, sort of looks at the safety of both steroidal and non-steroidal MRAs and heart failure trials, looking at different safety signals. So blood pressure or hypotension events, elevations in creatinine, reductions in GFR, elevations in serum potassium, and then also hypokalemia events, since that's also important in heart failure populations. And I know that there's a lot of numbers here. I'm happy to leave the slide on longer if anyone wants to dwell on the numbers, but I'll just sort of summarize to say there really are not pronounced differences between the steroidal MRA trials, spironolactone or eplerenone, and the finerenone trials in terms of differences in important adverse events that we care about clinically, either hyperkalemia events, hypotension, or reduced GFR. They, largely speaking, the event rates are very similar between the different trials. And this is a comparison that just came out last month. Looking at, again, comparing steroidal MRAs to the non-steroidal MRA in each of the heart failure trials, a conventional endpoint of CKD progression, so doubling of creatinine or progression to ESKD, in this case, decline in GFR of more than 57%. Emphasis was the eplerenone trial, TopCat was the spironolactone trial, Fine Arts was the finerenone trial. And you can see that each of these were associated with a slightly higher, but not statistically significantly different increase in risk for CKD progression in this population at low risk for CKD progression. If we looked at a more generous definition of CKD progression, so decline in GFR of more than 40% or ESKD, we see the statistically significant doubling practically of the risk for this endpoint in both Emphasis and TopCat. Finerenone didn't report it, but my hunch would be that we would see a very similar result given that these findings are very consistent. So with that, I'm going to segue into the MRA and CKD progression trials. I'm going to go fast through these trials. Feel free to stop me. We'll start with Fidelity. Fidelity, I think, as everybody knows, is the pooled analysis of both Figaro and Fidelio DKD trials. It was the only mineralocorticoid receptor antagonist trials powered to detect differences in the endpoints that we care about, CKD progression or end-stage kidney disease. These were multi-center phase 3 randomized placebo-controlled trials, and intended to capture populations at high risk for progression. So diabetic patients with albuminuria and retinopathy, excluded people with a potassium of more than 4.8 during the, and people who had symptomatic heart failure with reduced ejection fraction who had an indication for. And you can see the results here. The discontinuation rate due to hyperkalemia was low overall in this population who were screened out for hyperkalemia at baseline. And there were pronounced benefits on each of these 4 outcomes: that 14% reduction in cardiovascular events, a 22% reduction in heart failure events, a 23% reduction in the kidney composite, and a 20% reduction in dialysis. A game changer for management of chronic kidney disease. If we look at each of the kidney outcomes separately, you can see that finerenone reduced the risk for each of these events. So the composite outcome, but also dialysis, reduction in GFR, and each of these composite events. Okay, so this is what I wanted to spend a little time on. So this was an analysis stratified by eGFR and urine albumin to creatinine ratio from the pooled fidelity analysis. The top is showing the results stratified by GFR, and the bottom is showing the results by baseline UACR. In the top here, I think what you can see is that finerenone compared to placebo had similar efficacy for reducing progression in each of these eGFR strata. So the hazard ratios are very similar here, and this is a slide of the hazard ratio across GFR. If we look by UACR, we do see some suggestion that finerenone may be less effective with lower levels of albuminuria, but there's a lot of uncertainty here because there are a lot fewer patients enrolled in that strata. And this analysis looks at the safety of finerenone in the pooled analyses by GFR. So the left-hand side is showing the strata with GFR less than 60, and the right-hand side is showing the people with a GFR greater than 16. So I'll focus on the folks with a GFR of less than 60. If we look at investigator-reported hyperkalemia events, sorry, this one here, it was low overall, 18%. Oh, I guess not that low, but higher in the finerenone group than in the placebo group. Much higher in the GFR less than 60 than in the group with a GFR over 60. And these were treatment emergent central laboratory adjudicated events. 20% in the finerenone group had a potassium more than 5.5, though only 4% had a potassium greater than 6. This is an analysis that I thought was pretty interesting, published in the Annals a few years after the main trial came out. So the idea behind this study is that large meta-analyses of different therapeutic agents in CKD have shown that reducing albuminuria by at least 30% is an important surrogate marker for treatment's efficacy for reducing progression to CKD. So here, what they looked at is first, the extent to which finerenone reduced albuminuria by at least 30%. And what they showed in the top left-hand panel here is that more patients in the finerenone group achieved this surrogate marker of albuminuria reduction of at least 30% than did the placebo group. And then when they stratified the analysis first just by whether patients achieved an albuminuria reduction of 30% or not, they saw, again, what similar studies have shown, that achieving an albuminuria reduction of 30% was associated with a reduction in the risk for progression to chronic kidney disease. Then when they stratified by both achieving this surrogate outcome and whether they were on treatment with finerenone versus placebo, they saw that in both the placebo arm and the finerenone arm, achieving this surrogate marker, an albuminuria reduction of 30% or more, was associated with a reduction in both the risk for CKD progression and with cardiovascular events. Then they went on to do what's called a mediation analysis, like how much does this achieving this surrogate mediate the beneficial effects. And for the kidney composite outcome, what they found was that achieving an albuminuria reduction of 30% or more mediated 84% of finerenone's beneficial effects. It also was associated with mediating about a third of the cardiovascular benefits, but 84% of finerenone's effects were mediated through albuminuria reduction. So this really, to me, makes me wonder if that's the case, then would we not also expect that if a steroidal MRA reduces albuminuria, that it might be also similarly effective? So on the left-hand side are some of the earlier studies looking at steroidal MRAs and albuminuria reduction. This is one example of a trial that enrolled patients who had hypertension and albuminuria and followed them for about a year on top of RAS inhibition. And you can see that the eplerenone group, steroidal MRA in this case, eplerenone reduced albuminuria compared to the placebo. On the right is a meta-analysis of 31 trials with more than 2,700 patients that have looked at both steroidal and non-steroidal MRAs and albuminuria reduction. Most of the trials here are the steroidal MRAs because this is before the Fidelio analyses, and you can see that spironolactone and eplerenone both reduce albuminuria. This is confidence intervals are wide. So this to me suggests that all three agents reduce albuminuria, which makes me wonder then if that's the case, would we not also expect them to reduce CVD events? The last study I want to just talk about, and hat tip to Ian for pointing this one out to me, came out last year. It's called the Barak trial, and it looked at low-dose spironolactone and CVD outcomes in people with CKD. It randomized adults with CKD stage 3 eGFR between 30 and 59 who didn't have these exclusions to spironolactone 25 milligrams a day or usual care. And this was a pragmatic open label trial. So it has a lot of differences with the tightly controlled randomized trials that we talked about earlier. They had eGFR stopping rules. So like if the eGFR dropped by 20% or 25% from baseline, that treatment would be stopped. All of the patients were managed to achieve a blood pressure of less than 140/90. Here is what they found. There was no difference in the primary outcome of hospitalization, CVD, or death between the spironolactone arm and the control arm. More than 2/3 of the patients in the spironolactone arm stopped within 6 months, and this was primarily because they met the eGFR stopping rule. So their GFR dropped by 20% overall, or at 25% at any one visit. Here are some of the secondary outcomes. There was a reduction in blood pressure with the spironolactone arm, but this attenuated over time, presumably because a lot of patients stopped the spironolactone, a hyperkalemia. Okay, so I just went through a whole lot of data. How should we put this together? Well, this is kind of how I'm thinking about it. If we have cardiovascular or heart failure risk right here on the y-axis, going from no heart failure with preserved ejection fraction, and heart failure with reduced ejection fraction here, and then kidney failure risk here with albuminuria on the x-axis. This is where the evidence falls for the steroidal MRAs. You know, we talked about some of the limitations of TopCat. This is a trial in heart failure with preserved ejection fraction, but there's strong evidence for the steroidal MRAs in heart failure with reduced ejection fraction. We have 3 large, well-designed clinical trials demonstrating that they reduce mortality and cardiovascular events. In terms of finerenone, the non-steroidal MRA, we have strong evidence from fine arts that the non-steroidal MRA is beneficial in heart failure with preserved ejection fraction and in patients. Conversely, in people who have neither heart failure or proteinuric CKD, there does not seem to be a benefit of adding the steroidal spironolactone to standard of care vascular disease or hospitalizations. But this leaves us with some questions. Obviously, we don't know what to use, whether both steroidal or non-steroidal MRAs are effective in non-diabetic proteinuric CKD. But this is an area of active investigation from the makers of finerenone, so we'll get some data on this shortly. We don't know what to use in people who have both albuminuric CKD and heart failure with reduced ejection fraction. I'm not aware, it's been a while since I've looked, but I'm not aware of studies that are going on in this space. And I think an important question is there any reason to think that these would not be interchangeable? Was this just trial strategy, if you will, of where to test these agents? So in the end, I'll share with you where I come down on this. When it comes to the safety of these agents, I think spironolactone is clearly different as a non-selective MRA from eplerenone and finerenone. But from my standpoint, I don't see compelling evidence that there are significant safety differences in endpoints like hyperkalemia between eplerenone and finerenone. I think the trials suggest that the clinically significant events don't differ meaningfully between eplerenone and finerenone. So I would make the analogy of canned tomato sauce. This is branding, in my view. I have not seen compelling evidence that they're different. For the others, in terms of efficacy, so if we think that safety is the same, then it's really a question of effectiveness. Which one are more effective, or are they equally effective? And this is where we don't have an answer yet. We don't have a clear and convincing answer. I think the strongest argument for finerenone comes from the ARTS-HF analysis and this difference that they found in heart failure events in an exploratory analysis. But as I mentioned, this was an exploratory endpoint, an underpowered study, and might have been a chance event. So really, I think this deserves a dedicated study for us to really understand, is finerenone the Heinz ketchup of MRAs, or is it just one additional option that we have in our toolkit? And I think this question has not been sufficiently answered yet by the evidence that we have. And with that, I think I will stop here and thanks so much for listening. See someone in the back and then over there. This is a topic, this is a great and very important question. It is the topic of some ongoing studies. So hopefully we'll get more definitive answers to that. But there is some evidence that they're additive effects between at least the non-steroidal MRA and the SGLT2 that comes from both post-hoc analyses of the trial where they looked at the effects of finerenone in people who are not on an SGLT2 at baseline and on it, and they see similar effects. And then also some kind of neat crossover studies where they add people on it in short term and look at the short-term effects on albuminuria. And at least on the albuminuria endpoint, they look to be additive effects. So there's some reason to think that they might be additive. I will say also just since you mentioned SGLT2s, I think that's another reason to think that the safety differences that they advertise for being a big selling point for finerenone really diminish that as a selling point to me, because if everyone or most of our patients are on SGLT2s and SGLT2s reduce the risk for hyperkalemia, I think that becomes less of a justification for choosing a non-steroidal over a steroidal. I saw someone over here. So the analysis I showed is a post hoc analysis where they're stratifying. I'll go back to this. In that analysis, I'll get statistical. The p-value for interaction is not significant. Let me see if I can just go back faster this way. So they can't conclude definitively that there are differences. But I agree with your overall interpretation. I think you're talking about this data. I agree with your interpretation. What I think is your interpretation that there seem to be diminishing benefits at lower levels of albuminuria. And it kind of suggests that here because it does cross one. The caveat I'd make here is that the confidence intervals are really wide. So this is based on a pretty small number of subjects. But it does raise that possibility that it may be minimally effective in people who have very low level albuminuria. I wouldn't go that strong, but I would say that the VA DoD guidelines are likely to suggest that support the use of finerenone in that group. And not to say that it should be used in all patients, but it should be considered. Yeah. Yeah, that's a great question. I have been thinking about that too. Like, is this just a question that won't be important in a few years? Um, Possibly, but I do think there is still a reason to think about whether finerenone is more efficacious, more potent. Um, and even when the patent expires, I think there still will be generic pricing and brand name pricing, just as there exists for Clarinone. And so I do think that there is still a rationale for understanding whether there are truly effectiveness differences. Yeah, I'm thinking about. I'm not. I don't. I haven't come to firm conclusions, and you know, looking for feedback on this. But I am really focused on the CKD population with proteinuric CKD, both diabetic and non-diabetic. And my reasoning is as follows, which is I think we know that nephrologists are reluctant to prescribe MRAs. Like we already have good evidence for MRAs and heart failure, and yet even before finerenone, and yet we haven't been prescribing them. Um, and and I think the reason is because we have a lot of caution about the risks for hyperkalemia in people with low GFR and the effects on their GFR. Um, so I think the place where we do need stronger evidence is in the CKD population, and particularly in the people who are at risk for both. So that's where I'm focused. I also think there's an opportunity to look at it in the non-diabetic proteinuric CKD population. So maybe that's my nephrology centric way of thinking about this issue, but that's where I'm thinking there might be the biggest impact. What kind of scenario would I choose finerenone over spironolactone? I think if I was prescribing it primarily to prevent progression of CKD in a patient who was already on an ACE and an SGLT2, and the issue was not blood pressure control. I'll give you an example that I just got the day before I came here from our cardiology colleague. We have a mutual patient who has a heart transplant and is progressing due to calcineurin inhibitor toxicity and was already on beta blocker and ACE and SGLT2 and a GLP-1 and has proteinuria. And so for this patient, but does not need blood pressure control. So for this patient, we are thinking about finerenone. Yeah, I wish I had an answer for you. I don't have an answer. I will freely admit that I have not prescribed finerenone very much in the VA. I'm still grappling with this question of who is the right patient to use it for. I think I'm also practicing in the VA, and there's many more patients for who aren't yet on an SGLT2. And that's sort of been where my focus has been. Also, my practice is really focused on advanced CKD, so there are a lot of people who just won't be able to tolerate an MRA. So I don't know the answer to that yet. What is the right optimal albuminuria level? Great questions. Thank you.